You are listening to Armchair Healthcare, a podcast on pills, placebos, and policy.
All right, welcome to episode 2 of Armchair Healthcare. I'm Nat.
And I'm Max.
So what's the big news today, Max?
The really big news is that Amazon has bought a pharmacy and will be able to start selling pharmaceuticals in 49 states.
Are they going to revolutionize healthcare with this?
Not going to revolutionize healthcare. I mean, they didn't really revolutionize much. I mean, they're just...
They revolutionized retail, Max. Come on. Give Amazon credit where they're due.
I mean, I would think LL Bean are the people who really revolutionize.
Okay, that's a totally different podcast.
It is a totally different podcast, but I mean, in effect, it's mail order. It's just mail order on the internet.
Then Sears Roebuck revolutionized.
Yes, that is true.
You can have more than one revolution. We don't have to just say one company revolutionized X. They can be multiple companies, like 1 or 2 per century, right? I think.
Well, yeah, but I mean, it's still more of an evolution, I would say. But I think what this does signify is that, CVS and Walgreens, which historically have had, 50 to 75% market share in the major metropolitan areas, are in trouble because, between, Amazon's ability to, compete on price and convenience, and Costco and Walmart definitely competing on price, I just don't see why people would really go to CVS and Walgreens other than the fact that, well, they're just my neighborhood pharmacy that I've always went to.
That makes sense to me. I mean, I don't think they're going to go away either. I mean, even in the long term, because it's not like Amazon drove away, just basic brick and mortar stores. There's still basic brick and mortar stores out there, right? Like the grocery store and everything else, because sometimes you need to go to the grocery store to buy some groceries. Sometimes you need to go to the drugstore to buy some drugs, right? You need it turn around quick. You need some antibiotics. You need flu medication. You need whatever. So I don't think those guys are going anywhere. I think this is much more an acquisition targeting. And if you look at the actual target, this what's it called, pill pack? Is this something for people with chronic diseases, right? This is what I would imagine. Chronic diseases that are going to be taking lots of drugs. They get them by mail order because they know they're going to need them in a few months, right? So they order big packs of pills and do it that way. But that begs the question to me, I mean, doesn't that already exist? Aren't there already mail order pharmacies? I mean, what exactly is Amazon going to add to this proposition?
Well, I think they'll compete on price, and then they'll also, Amazon Prime is really nice. I mean, sometimes you'll order something and it comes the next day and you didn't have to pay for shipping. That's very nice. That will kind of eliminate a lot of the advantage that some of the brick and mortar stores have, because you can just go there and get the medicine, that day usually. Mm-hmm. So, and do you think
they're going to be able to do that? I mean, just looking at the PillPack website, I believe it said it had like a 1-month turnaround.
Well, just for that first shipment, because if they need to get any prior authorizations in place, etc., it's very bureaucratic. But they also said that they can give you some pills to tide you over until that starts. So I think they can be relatively quick. Okay. I think the algorithm that PillPack has is pretty valuable, and then Amazon will be able to really help on the logistics side. So, what PillPack is, it's not just a mail order pharmacy. They will actually put all the pills that you need to take on Monday morning, July 1st, all in one pack. So you just open it, you take your pills, and that's it. And that should increase patient compliance, decrease patient confusion, because they might be like, oh, am I supposed to take this at night? Am I taking this in the morning? And also from what I could tell from the website, they can do that with vitamins as well. And I know I'm probably an outlier, but I take several vitamins every morning. Mm-hmm. And it would be nice if I didn't have to spend some time opening all those stupid pill bottles and, getting those pills. If I could just have a pack prepared for me by Amazon, I mean, that would make me a very loyal customer.
Yeah, it makes a lot of sense. And I know just the pill burden becomes a huge, huge limiting factor in terms of compliance. I saw some statistics sometime regarding HIV patients where, and this is a disease where you got to take your pills or you're going to get sicker. You have to take them for the rest of your life. But sometimes the pill burden will get so high that on average they had, in the, 50, 60% compliance. So a full on 40% of people weren't taking all the pills that they were supposed to because they had to take so many of them.
Yeah, no, that's definitely been an issue. And also, you just get, you'll forget, did I take that pill? If you're taking like 7 pills in a row, you're opening like 7 bottles, unless you have them all like lined up, you can very easily forget which ones you've taken. Did I already open that one? This will help just kind of eliminate overdoses and underdoses. So I can definitely see the potential for this.
Right, so we're both on board. We like this merger. We like this company, PillPack, even though I never heard about it until this merger was happening. But thumbs up. Synergies. Synergies are good. I love synergies. But yeah, we don't have to worry about Amazon running out all the mom and pop pharmacies because that's already been done. There are no more mom and pop pharmacies left.
Pretty much.
Yeah.
Pretty much. So, I think the other big news that we had this week was in the 14th Congressional District in New York, there was a socialist who was able to defeat the person who was going to be or possibly be the next Speaker of the House in a primary. And one of her planks of her platform is single-payer medicine.
Max?
We are talking politics, but in a judgment-free way. We both have implicit biases, but generally on opposite sides, so they can cancel each other out and we can have a nice conversation. Not like the ones you have on Twitter where people go crazy.
Anywhere regarding politics, people go crazy.
And we'll talk about religion next time too.
All right, that sounds great. I'm excited.
The single payer thing, I think you hear more and more people talking about it, and while it's not really possible, if there's enough of a anti-Trump wave in 2018, 2020, there's a filibuster-proof majority in the Senate. You could see, something like single payer get, passed. And then there's already several different proposals out there in the Senate. Like Bernie Sanders has a Medicare for all proposal, which basically puts everyone on Medicare. The Center for American Progress has a Medicare Extra proposal, which is just kind of a Medicare option is available for everyone, but they don't have to have it. And then other things with Senators Bennett and Kaine have one where it's just an option on exchanges, whatever. But let's just focus on single payer.
Just to back up for a minute, I just heard a statistic on, I believe it was This American Life regarding single payer healthcare. And it's actually remarkably popular amongst the electorate. I think they quoted around 60% public support. So it's the type of thing that even though it might not be politically viable right now, on the ground, a lot of people in a survey say they agree with it.
Well, I don't know. I don't know who they surveyed or how the question was really worded. And that kind of flies in the face of other polling data that show that 80% of people are happy with their current insurance.
Those two things can coexist.
I don't know. I think people just don't know the reality of single payer. First of all, the hospitals will lose all of their profits if they had any. The hospitals tend not to make any money on their Medicare, Medicaid patients. They make all their money on the privately insured patients. So if you make everybody a Medicare and Medicaid patient, they lose all their profits. And, that could lead to some hospitals shutting down. Or, in other cases, I think they might just start cutting salaries for doctors. That's generally what happens in nationalized healthcare countries. Doctor salaries are much lower than they are here.
To put it into perspective, doctors make by far the most money of any profession, including CEOs, bankers, anything like that. They make significantly more than anyone else. So I think there's room to come down. I'm not the first person to say that. I think doctors definitely should be paid well. They've been to quite a lot of school at quite a lot of expense, and it's not an easy job, and they have long hours. But they are incredibly highly paid in this country on average.
Well, maybe on average. It depends on the specialty. So general practitioners are not that highly paid. It really depends if you're doing procedures. If you're doing procedures, you're paid more than if you're just doing office visits. The problem is if we start cutting the salaries of doctors, who right now I think already they don't really make much money until they're in their 30s. So if it becomes like the 40s or the 50s before they kind of start making any real money, they just won't become doctors. We're just going to end up with more lawyers and finance guys and tech guys.
But the trade-off on the other side of that is that you're, with any luck, going to be increasing the level of access to care. So although there might be fewer things available, more people should be able to access more care.
I don't know, but how many people are actually who need the care can't access the care? I know there's a statistic out there about the number of people without insurance, but I think a lot of those people tend to be young. So they're not necessarily sick, so they don't really need the care.
Well, I mean, the question is how many deaths that are preventable are caused by lack of access to care in this country. And I think there's quite a few, because a lot of times people are not going to the emergency room because they know it's going to be a huge bill, right? Or they're putting something off. They're not doing any preventative care because they got to pay for that. And so what happens is things escalate to the point where they're going to the emergency room at the last minute because they have a blood infection in their leg or something like that. They didn't go earlier. They didn't take care of it, right? And so all these things decrease the efficiency of the system. They make for worse outcomes. I mean, that's what people are trying to avoid. But yes, the trade-off is you are going to have, at least in the public part of the system, and it should be worth noting that most systems with universal healthcare also have private components that complement and provide these additional benefits if you want them. A large number of people in the UK, for instance, have private insurance, and that's just for these extra things that you might want. But I think it's really a question of delivery of care. Right. We want people going to the doctor. We want people to feel comfortable doing that. We want people addressing their health issues, because in the end, somebody pays for it. Right. In the end, if it's not the individual that's paying for it, then it's going to be socialized anyway, no matter how it's set up, no matter what the system is in a society where we're not going to let somebody die because they don't have money. Right.
Yeah, so I mean, I think the problem isn't necessarily access to care; it's the price of care.
But don't you think our system right now is a pretty good example of how price of care can escalate out of control?
Well, yeah, because the healthcare sector is really the only sector in the economy where there really are very few market forces at work. I mean, you go to the doctor, I mean, you know how much you have to pay, but you don't know how much that visit costs because the insurance company is taking the rest of the bill. You don't really know how much your drug costs because you just have this flat copay. It might cost CVS 30 cents to fill that prescription, but you're paying $5 or $10. If you're in hospitals, it's even worse. You might, if let's say you're a lot of tourists who've come to this country, something might happen, and then they try to find out like which hospital they should go to and what the price would be for whatever procedure they need at those hospitals. They can't really get straight answers. So and then they get like this giant bill at the end. There's no way for people to know how much something costs, and because of that, hospitals, other providers can just charge whatever they want. And also there's this belief that people's lives are priceless. You can't put a price on a human life. So now we have a world where drugs have infinite prices. I mean, pretty much. I mean, like for anyone with an orphan disease, you're basically buying this person a house every year for the rest of their lives. And, because of kind of lowered standards at the FDA, you don't even know if that drug is working. That's all adding to the costs in the system. I mean, I remember seeing a statistic, I believe it was from United Healthcare, that 1% of drug use is 40% of total drug cost. So, and, I think, one of the things that, I think the whole paradigm, even though I hate that word, the whole paradigm of how we treat healthcare in this country is wrong. I don't see why it should be an insurance system. Like you usually have insurance on your house. So, if there's a fire or a tree falls on it, like you get covered. So these kind of highly infrequent, improbable events are covered. So healthcare is something, though, you use pretty frequently. I mean, imagine how crazy it would be if we had food insurance and you had to get a prior authorization to get baby arugula. I mean, it would be insane. And it would be, as insane as our healthcare system is now. I mean, it's, a lot of people are, I think, overusing healthcare kind of on the lower end because they might have really nice insurance and, they're only paying, $5 or $10 copay. So, for example, when my eldest was, still an infant, if he had the slightest increase in temperature or runny nose, we just run to the doctor because, why not? Let's just check just in case. Well, I mean, every visit, probably costs the system like a couple $100, but it cost us, 5 or 10. So we were constantly doing that. So, a lot of people can just, I should really get this looked at, and they go, but it's nothing. And then there's also there is a trend towards overdiagnosis, which is, costing the healthcare system, money and making things just generally more expensive. So I think we need to have kind of like a mixed system where you do have healthcare savings accounts where you pay out of pocket for some of these items. So that there's an incentive out there not to overdo it.
Yeah, but the question then is the problem in general with healthcare. What this brings me to is people. The reason why they go to doctors in the first place is because they aren't fit to judge their own medical risks, right? You let's say you get a mole or something like that. You go to the dermatologist to get it checked out because you don't know if it's going to become cancerous or not, right? And if people are trying to make these sort of financial decisions regarding their quality of care, they tend to err on the side of, okay, it's probably nothing. I don't want to spend the money, right? When in reality, you do need those moles checked out, right? If you have a new big old black mole, you should have somebody look at it. And this goes on back to the problem of access to care. I mean, if there is a financial burden associated with these healthcare visits, right, then people don't get the sort of preventative care they need either, which in the turn lowers healthcare costs over the long term, right? I think, in theory, right? I definitely hear your critique, right? There needs to be some sort of feedback, right? There needs to be some sort of, I don't know what the right word for it is, an oppositional relationship like any other sort of market-based system, right? Between the patient and the provider, right? But I don't know how you make that work when it's strictly in the patient's better interest to utilize as much healthcare as possible.
Yes. I mean, I think that, right now, let's give an example of Sarepta's drug. It's a $300,000 drug, and the FDA has referred to it, or people at the FDA have referred to it as a scientifically elegant placebo. Now, those parents of, kids with, Duchenne's muscular dystrophy, I mean, it's a horrible disease. I mean, you can't blame them for this, but, they have no incentive not to push to get that $300,000 a year drug. Now, let's say they even, they have to pay for part of it, and it would be a significant part. And, they might have to decide, well, if we pay for this, we'll have to, remortgage the house or something like that. Maybe they'll make another decision just based on the fact that, the evidence isn't really there. Maybe we shouldn't, have this drug prescribed. They're trade-offs. And right now people aren't making those trade-offs because they don't have to.
I don't know. It's tricky because I think people, when they quote unquote review the evidence, right? People that are untrained routinely make horrible health decisions, right? This is the reason why we have this whole debate about whether vaccines cause autism, because people believe they reviewed the evidence and they found a link when this is blatantly false. So, I mean, that's the thing. I think really what we need is greater access to qualified personnel. Now, does that need to be a doctor? Maybe the solution is having better triage, right? Right now, it's everyone demands to see a doctor. You go see a doctor, you get a big bill, right? Maybe we need better triage where there's somebody, an intermediary that says, all right, you have strep throat, here's a pill. You don't really need to see a doctor. I can take a swab and figure this out, right? Maybe we need something a little bit, since the doctors are qualified, are really high paid. Maybe we need more people sort of there in the middle that can help triage patients a little bit better.
But I guess the question is, how do we do everything that we want and still pay for it? Because, right now, I think we're going to have a $1 trillion deficit this year.
Yes, I saw that.
So if, our finances are kind of really horrible. So I'm not sure if we can afford like a single payer or like pay for all these drugs that everybody always wants. I mean, at some point we have to make trade-offs. Like everything is not infinite. We can't all have, Ferraris. You have to make kind of some decisions. And I don't know, it's not an easy question to answer. I mean, there's just so many different moving parts. Like I remember when there was healthcare reform, attempted by the Republicans last year. I mean, it was just all so complicated, and you kind of just wish that people would just stop trying to mess with it, actually, because it's almost like anything that no matter what you try to do, it always seems to make things worse.
Well, it definitely makes our lives more complicated, Max, as healthcare analysts, trying to keep up with the constant sort of shifting sands of how people, how these policy wonks are thinking about things.
Well, but it's been great for all the drug companies because, I mean, I remember when
they're doing great. And the insurance companies, really everyone in the system is winning except for patients. Drug companies are doing great. Insurance companies are doing maybe even better.
No, the patients are actually doing fine. There are new medicines coming along, like, the CAR Ts.
Yeah, but there's a dramatic rise in the number of bankruptcies associated with medical.
True. But I think it's also the non-patients who are really getting negatively impacted by all of this, because let's say they're relatively healthy, but their insurance premiums go up every year. I mean, with car insurance, if you've been a good driver and you haven't had any problems for a few years, your premiums go down. That's the exact opposite of what happens in healthcare.
Somehow we have to make the stuff better. I don't know. That's all I got.
Okay. Well, so I think we need to go on a little bit of the lighter side of things, because
yes, it's always depressing talking about
intractable problems.
Intractable problems that are killing people all the time.
Yes, it's a major issue. So last podcast, you asked me about kind of like what my favorite fraud was.
Oh, so we maybe should make this into a new section of the podcast. The fraud of the week.
Oh, yeah, sure.
What's the fraud this week, Max?
Well, there are so many to choose from, but I remember there was this company like GPC Bio. It was a German company. I think this was around 12 years ago. They were developing satroplatin for prostate cancer. So it's a platinum-based chemotherapy. So nothing, not some outrageous...
Same stuff that everyone else is developing.
Yeah.
Or has developed.
And like their data was... So they came out and they were saying that the FDA had given them an SPA for this composite PFS endpoint. So, with prostate cancer, PFS can be hard to measure. So they had this composite which included pain and I believe like bone mets and etc. So, they had been telling people for a very long time that the FDA was okay with this endpoint. And in their phase 3 trial, they hit the endpoint with flying colors. There were several zeros in the p-value. But when they got to the day of the panel, the FDA spent a good 10 minutes talking about how the company has no SPA with the FDA and that they've repeatedly told the company that we do not like this endpoint. It does not make any sense. Even your pain scale sucks. So it was kind of like, it was just amazing that this company who had some high quality investors, had been going around the street, seemed pretty credible, was just lying to you.
Maybe it's because they thought their protocol was really special and the FDA assessed it. So maybe it was just used that SPA in the colloquial sense because people do that.
Yeah, they do, but they usually don't. I mean, I think it was even in their SEC filings. And so this is what actually happened. Because the FDA basically gave a whole timeline of exactly what they said when they said it. So they were basically saying, no. And then finally, after the company has asked them several times, they said, okay, it's a review issue. So they didn't say we like the endpoint. They just said it's a review issue to get the company to shut up. And then, for the first good 10 minutes of the FDA advisory committee, just told them, we still hate your endpoint.
Mm-hmm. That's great.
Yeah.
I know we've talked a bit at this point, only 2 podcasts in, about the ugly of the biotech stock market. How about the pretty. Is there any company out there that you like, Max? You know what I like? You know who I like? Pfizer.
You like Pfizer?
I'm just kidding.
It's okay to like Pfizer. Like
No, they're fine. I actually like Pfizer in the sense that they've managed to operate very efficiently and come out with drugs. They're never the first for anything. At least they haven't been for a long time. But they'll make the second or third drug in a class and end up selling $1 billion of it.
That's true.
And they've got like pretty damn good margins, right?
Yeah, they're pretty efficient.
They've been steadily improving their margins. At least last time I checked. They've been improving their margins since at least the days when they actually did R&D in a major way. Yeah, so that's a strategy.
Yeah.
Be the second person, third person to come up with a drug and just not really invest in discovery.
Well, it's really, I think they've gutted their discovery pretty thoroughly. And also it's really hard for them to be first in anything. I mean, I don't know what it is now, but I remember at one of their analyst days a while back, I was sitting next to the general counsel, and the theme of the analyst day was how they were, cutting bureaucracy in the R&D organization. Mm-hmm. So, I asked them like, how many levels of, bureaucracy do you have in R&D now, and what did you have before? And so he's like, oh, I think we went from like 12 levels to 8. So still highly bureaucratic, committees upon committees upon committees.
Yes. So I've worked in big pharma a little bit, and I will tell you there are a lot of committees. Right, we used to go through. I was a chemist, so it's just in the discovery part. So we would have committees on like a monthly basis just to go through the dead leads. Say, okay, everyone's okay, just not following up this lead. This molecule is just dead. Like, let's not work on it anymore, and let's let it go.
What was the criteria to judge whether a molecule is dead?
Not doing anything. Generally, it was like, okay, we made this, and it doesn't really do anything.
But do you test it do you test it in like a specific disease, or do you a whole range of diseases? Like, how does it work?
Oh, you have your individual projects, and you normally have some sort of structure that does something, right? It either binds to the protein or whatever, and you sort of tweak it around, move a functional group here or there, and try to make it bind better. That's the idea. And you might have there might be several sort of leads like that on any given project, like with sort of different shaped molecules that some chemists could be working on, and several of them at the same time. And at least when I was there was you would have a couple different projects at any given time.
Do they still have a lot of chemists, or are they really just a marketing organization now?
Oh, the big pharmas? Yeah. Well, they've always spent more money on marketing than on R&D.
Just kind of getting back to our healthcare pricing thing, that just reminded me of how they always say that they need to have high drug prices to justify their high R&D expenses. Mm-hmm. But if you actually look at it, they don't really spend that much on R&D. And if you look at them as if you compare like the pharmaceutical sector to every other sector in the economy, they basically have higher operating margins than everybody else. I mean, we're talking about double or triple the average. So, kind of the pharma argument really doesn't make any sense. It sounds really good.
Well, I will say that just from basic economics, they're going to charge whatever price they can charge. It doesn't have anything to do with anything, right? It has to do with the amount of money people are willing to pay. It depends on the cost, except that it has to be higher.
Yeah, but right now we have a system where the end user isn't the one actually paying the price. So they can charge almost whatever they want, especially for like a cancer drug or DMD. I mean, that's what happened. I mean, people for the last, 20 years, companies have been pushing the envelope. I mean, I remember when I believe Enbrel was like a $20,000 drug, and that was like on the higher end. And then Erbitux came out, that was like $50,000, and people were like, whoa. And then we had Avastin, and that was like 90,000, and people were like, kind of amazed. And now we're talking, it's really easy for these companies to charge $150,000, $200,000 for relatively big indications. I mean, it's no longer just some ultra orphan indication like Gaucher.
Mm-hmm.
It's more and more cancers are being treated with these drugs that cost over $100,000, and they are doing all these trials where you combine a couple of these really expensive drugs together. I don't know. Seriously, I don't know who is going to pay for any of this.
Well, before too long, it's all going to fall apart. I mean, it can't go on like this forever.
Yes,
right?
whatever can't go on forever doesn't.
And I just want to step back and I actually think, first off, disclaimer, like, I know I work in the pharma industry. I know I worked for a pharmaceutical company. I just mentioned that. And I don't think these pharma companies they're not saints, but I do think they get kind of a disproportionate amount of flack for their role in driving up healthcare prices. I mean, yes, they are doing this. Yes, the prices are insane, but proportionally, they're like, what, mid-teens, like 15, 17% of all of healthcare spending?
Yeah, so they're just the part that people can see. So you can kind of generally, unless you're very ill, you're not going to the hospital all the time, but you might be filling a prescription all the time, or you might be paying co-insurance on that prescription. So you kind of see that bill. So obviously, it's kind of like the devil you see in front of your face every month.
That's true. And people really don't like pharmaceutical companies. I mean, I saw the thing today. There was some statistic that like 80% of people, 80 to 90% of people think the pharmaceutical industry has too much control over our economy. That was ahead of bankers, which kind of are the economy. So they're the devil in most people's eyes. And it's a complicated issue. And the thing is, too, this gets back to our previous discussion of this healthcare costs in general. They're going to continue to charge these prices as long as it makes economic sense. And that's not a moral judgment. It's just that they might end up saving, like Gilead's Sovaldi at $85,000 per course of treatment was still saving money to the healthcare system.
Yes.
Right? So it was still a valuable proposition. And that was simply by virtue of everything else costing so frickin' much.
Yeah, I mean, that's actually a really good example. I mean, you look at Sovaldi, I believe, though, the price has gone down effectively to maybe $35,000 or $40,000.
Yeah, it's startlingly low compared to where it was before.
It actually cures people of this horrible disease. So, on one hand, you have this one drug that can cure a lot of people of a chronic disease, through a course of treatment, costing about $35,000, $40,000, and then you have these others might be $300,000 a year, and you don't even know if they work. Mm-hmm. It's just it's all kind of messed up. I mean, but the only reason historically the reason the orphan drug companies have been able to charge so much is because none of the companies had too many of these patients, so it was never a big line item. They were always worried about the the Lipitors, etc. The ones that are going to be one of their top 10 drugs. So Sovaldi, because there were a lot of Hep C patients, the insurance companies really pushed hard on the price, and they were able to really get it down to what I think was, you could really argue was a nice price.
I mean, is this the system working? Is this the sort of balance of power that we're talking about working in this instance?
Yes, because the insurance companies, finally, the insurance companies cared, and they were also, it seemed like they weren't afraid to deny treatment either, because that's kind of the whole thing, right? Mm-hmm. It's like that the insurance company has no power unless they're able to keep a drug off the formulary. And there they were obviously able to threaten Gilead enough that they got massive rebates. And so the actual realized price was pretty low for a pretty great drug. Yeah. But they don't care about everything else. It's like they don't have their staff is there to hound the doctor's offices to make sure that every line is filled in a prior auth. They're not out there like...
True. I mean, that's where most of the costs are going. So, I mean, it kind of makes sense from their perspective, right? And because there's lots of unnecessary stuff going on in doctors' offices too.
Yes. And another problem is that, and I remember the current Secretary of Health and Human Services, Alex Azar. I saw him speak at the Manhattan Institute a few years ago. He pointed out that one of the issues is, a drug might actually be very cost effective for the health care system as a whole, but it's different people managing different parts of the insurance. So you have the PBMs managing the drugs, And then you have kind of the payers handling kind of the doctor's visits, the hospitals, etc. And while you think things should like flow through enough that the PBMs would really try to kind of save the rest of the system money, that's not how it works. They don't see a direct benefit from this drug. So they're just trying to restrict access or not really care about it or whatever. Like there's no like mind behind the system.
Why do PBMs even exist? Why can't the insurance companies handle this on their own? This is what I don't get. Like they just seem to be a bit of a leech on the system. I mean, I get their purpose. They're supposed to like negotiate for, these drug prices for these insurance providers, right? But no one knows what price they're actually negotiating it to, except for the drug companies and the PBMs. And it seems to me like there's these inherent problems like you're just talking about right now. Like, shouldn't this be the burden of the insurance company to begin with? And that's one of the more interesting things I saw in the Trump's proposal regarding reforming drug prices, right? Was to insist on a fiduciary duty of PBMs. So they will have to act in their financial best interests, which they obviously aren't right now.
Or was it the patient's best interests?
No, it's insurers.
Okay.
I believe, yeah. Well, here's a question for you, Max. You think Medicare works pretty well, right?
In certain aspects. One of the issues with it is...
But that's pretty much a single payer. That's a single payer system. Devil's advocate here. I mean, if it works pretty well, it's such that people will leave their private insurance to get on Medicare.
It is going bankrupt in like several years.
Well, yeah, that's the whole other problem. People actually have to pay for this stuff.
Yeah, so Medicare is working fine, except for the fact that it's on the road to nowhere. People aren't paying enough in terms of premiums and copays to actually pay for the care they're getting. And look, if we ever expand this to everybody, then we seriously will go bankrupt, or we'll have the currency.
We'll have all the
Turkey.
money that we were spending on health insurance, which is a lot, available to pay those taxes, right?
Assuming that the government can do something more efficiently. They'll just add more bureaucrats.
That's a whole different question of whether the government can actually do it.
Think about it.
It really depends. I think the FDA does stuff pretty well. Right? There's some government agencies that seem to work reasonably well. NASA put man on the moon.
Well, okay, so the FDA historically did not work very well. I remember Claritin, I think, took like 8 years to get approved. This was before PDUFA. Mm-hmm. So with PDUFA, the industry started paying the FDA, and the FDA got better, more pro-industry. And also one problem with the FDA is they don't look at if something is cost effective. So they kind of throw their hands up, they lower the bar, they approve everything, and insurance companies have to pay for everything, or they generally pay for everything for anything serious, whether or not a drug works at this point. And you're seeing this more where the payers are willing not cover something. But the pressure is always intense from the patient groups. And you had a decision, CMS sent out a letter the other day about how, state Medicaid programs have to cover FDA approved drugs, even if they're approved under accelerated approval. So under accelerated approval, the burden of evidence isn't necessarily high.
Yeah.
So, you're having the FDA kind of abdicate their responsibility for whether something's cost effective. And then the people who can potentially make a decision on whether something's cost effective are not allowed to.
So you're saying the whole system is fakaked?
Yes, definitely fakaked. But again, not something that we will ever, I don't know how we're ever going to solve this. Seriously, it's just...
Yeah, there's a whole bunch of countries where, it works better than here. And some of them aren't necessarily single payer. Germany doesn't have a single payer system, but it works. They have their insurance market is really heavily regulated and all not for profit.
Well, taxes will have to be a lot higher. We'll probably go into like a massive recession. People's quality of life will go down. You could say that Americans are just more consumerist, and maybe this will put a handle on that. But I don't know. It's really hard to get there from where we are now.
Yes, that is true.
And especially with kind of, right now the Democrats and Republicans aren't working together. They probably haven't been working together since, I don't know, the 80s, 60s. it's really rare to have like good bipartisan legislation that has like broad support. Everything's like just one side or the other.
It's true. We should start our own system, Max.
I'll leave that to Elon Musk, who I think
what is he doing now? Is he starting a country on the moon?
Mars.
Mars.
No, someone asked him what his the system of government would be for Mars, and he gave an answer, and it was just really weird. It was like something from some utopian socialist in like the 1880s.
Yeah. He's come under a lot of flack recently for simultaneously saying that he's a socialist and then crushing unions. So good job, Elon. Good job.
So I think that's all we have today. Thank you for listening, and please make sure you subscribe.
And thank you, Max.
Thank you, Nat.
Our theme music is by Hazar.